Okay. Good evening, ladies and gentlemen. Once again, my name is Geetha Venkat and I'm your host for this evening's webinar. So tonight's topic for discussion is endometrial receptivity, in particular focus on the ERA, EMA, and ALICE tests. So first, I'd like to start by introducing you to our panel of speakers. We have Dr. Geetha Venkat, who's the director at Harley Street Fertility Clinic, and Dr. Alan Thornhill, who's the Senior Scientific Advisor and UK Manager for Igenomix. So the topics that we'll cover are a broad overview of why do embryo transfers fail, and that will be provided by Dr. Venkat. And then we'll move on to the specific bit of endometrial receptivity, which will be covered by Dr. Thornhill. The event will be recorded and uploaded on our website in due course, that you can review it if you missed something or forget. We will have a question and answer session at the end, so please raise your hand or submit questions via the Q&A function on the Zoom platform. If you want to stay anonymous, that's absolutely fine. You don't have to state your name, and your camera can remain off. So without further ado, I'd like to hand over to Dr. Venkat to get us started. Thank you very much.
Thank you, Suvir. Good evening, ladies and gentlemen. Thank you for sparing your Friday evening for this webinar. This is a very important topic and will be very useful to many of you. So let me just tell you how we started doing this test in our clinic. Alan and myself, we work together. We know each other for many years. And one day when I met him in a conference and he's told me about this test, and we arranged for him to do a presentation in our clinic, and we were so impressed and we started doing it. And now we have been doing it for the last 2 years, I think. And I have to say our success rate has improved a lot with this, because we are able to time our embryo transfer according to the individual cases. Previously, we were having one, size for all fits all, the story, because we did the standard implantation time was used for our embryo transfers. That was the protocol we followed. Now we go according to the personalized embryo transfer based on the ERA, EMA, ALICE test results. So I have to say thank you, Alan, for introducing our clinic to this test, which we find very useful. So coming back to the topic, I will say, look, if the treatment doesn't work, IVF treatment doesn't work, or, after embryo transfer, somebody doesn't get pregnant, we might think why it didn't work. That is the first question all the patients ask us. And sorry, I didn't turn the camera on, so I'll do that. So you have to turn it on, it says.
Okay, carry on. I'll try and figure that out.
It says the host has to turn it on.
Okay, I will do that.
Okay, yeah, okay. So that is the first question asked by the patients, and we try to find the answer. So we go through the notes and see what could be the causes. I will say the cause of any failed treatment could be from the embryo or from the implantation side or the uterine side. These are the two places we have to look for the causes. And if it is the embryo issue, then we say it's the quality of the embryo for implantation, as well as the genetic content, that is the pre-implantation genetic testing, which will tell us whether, which will tell us whether, the embryo is chromosomally normal or chromosomally abnormal. So that's an important test, which will rule out the problems on the embryo side. Say, for example, we do the test in our clinic. We recommend all our patients to have this test so that we rule out the problem with the embryos. We aim to transfer euploid embryos, that is chromosomally normal embryos, thereby reducing the risk of miscarriage, as well as reducing the time to getting pregnant and having a healthy baby. So if you do that, then you are ruling out the problem from the embryo side. And the next factor is like you see the equation, egg and sperm is embryo, then next one is the receptive uterus. And if there is a problem with the uterus, there could be two things. One is whether we are putting the embryos at the right time. Like we always say, you have to be in the right place at the right time. So the embryo has to be transferred at the right time, right implantation window. That's important. And other causes could be some immune issues which interfere with the implantation. Next slide, please, Suvir. Right. So if this slide is a busy one, you can see. However, it gives a clear picture of all the underlying causes where things could go wrong. And now you look at it, so possible source is the egg. What are the things that can go wrong with the egg? This could be some genetic causes. And how do we find out, first of all, whether the woman has got good ovarian reserve or not? That is tested by the scan as well as by the hormone profile. And similarly for the sperm, we do the semen analysis and sperm DNA fragmentation test. And I just mentioned to you for the embryo, we do the embryo assessment as well as pre-implantation genetic testing. And when I mentioned to you about the uterus, there are few things we have to. Are there any abnormalities in the uterus, physical abnormalities like bicornuate uterus or septum in the uterus? These things make the uterus very weak and then cause miscarriage as well. So physical abnormalities, or the endometrium doesn't develop well. There could be some adhesions or scar tissue in the uterus which prevents the normal development of the endometrium or the lining of the uterus, in which case, again, we could have problems. That is detected or diagnosed by saline infusion scan, which is done routinely in our clinic, which detects any pathology in the uterus. And if we suspect something like polyp or scar tissue, then we recommend the patient to have hysteroscopy to clarify the situation and also treat the problem if it is present at the same time. So that is the next one. And then in the uterus itself, there could be physiological causes. And that is the one we are going to focus on today. That is the ERA, EMA, and ALICE. That is endometrial receptivity assay. We are checking to see when the endometrium is most receptive. So normally we do the test as per the usual protocol. I'm sure Alan will go through it, but I'll just briefly tell you what it involves. Like we follow the protocol as per the frozen embryo cycle. Someone is going to do natural cycle, we follow natural cycle protocol. Or if it's medicated cycle, then we do the down regulation and start the woman on estrogen tablets. And when the estrogen level is optimal, as well as the endometrial thickness is optimal, then we start the woman on the progesterone. So the standard practice is to put the embryos or transfer the embryos after 5 days, 5 full days of progesterone injection or pessaries or whatever we use. But that is the time we do the endometrial biopsy, and then we send it to the lab and they check and tell us whether it is the right time for that woman or is it different. And then they will tell us when we should do the embryo transfer. And we have followed this in so many patients, and I'm happy to say they have been successful. And of course, the other factors, which I'm just saying for completion's sake, is the endocrinological. We check all the hormones and the relating like thyroid hormone, the other hormone profiles we check. And then other issue we are concerned is about the immune factors. And that is dealt with by the reproductive immunology tests and then immune treatments. And we had a webinar recently about this. It's been recorded and it's in our website. So we are now going to focus on the uterine factor or physiological factor about the uterus. Now, before I hand over to Alan, I would like to say about different definitions so that we are clear about what we are talking. So endometrium, everybody knows that is the inner lining of the womb or the uterus. And when we say clinical pregnancy, it means confirmation of the pregnancy in the scan with the fetal heart. That is clinical pregnancy. Biochemical pregnancy is also equal to very early miscarriage. So that means someone has got positive pregnancy test, but before they come to the stage of scan, they start bleeding. Or if you are measuring the beta HCG levels, it's good level to start with or positive level, and then it starts going down. That's called biochemical pregnancy. And miscarriage is loss of pregnancy in the first 24 weeks. It can be any time. When it happens in the first 12 weeks, it's first trimester miscarriage, and then it is second trimester miscarriage or late miscarriage. And recurrent implantation failure is different, where there is no implantation of the embryos. So if we have had 3 failed transfers with the embryos, or 3 embryos have been transferred and the treatment has been unsuccessful, here I have to say they should be good quality embryos and also chromosomally normal embryos. Only then it really means recurrent implantation failure. If the fault is, or if the issue is with the embryo, like low quality embryo, then this doesn't come under this category. So these are the definitions. And so for the endometrial sort of embryo implantation, I would like to say endometrium must be most receptive. That is the phase we call it as implantation window. And that is the time the endometrium is prepared well and matured well, and it is ready to receive the embryo. And the embryo is able to attach it and burrow into it so that it is able to implant. So there is a dialogue between the uterus and the embryo, and that happens, and both sides should be attracting each other. It's like a friendly, cohesive approach. Supposing one is against the other, nothing happens, then the dialogue doesn't happen well, and then the embryo implantation is prevented. It could be, like I said, problem with the embryo, problem with the uterus, or some extraneous factors like immunological factors. So we think this is what we know at present, but the whole thing is so complicated, it's difficult to study. And as the years go by, we will have more information about it. So I'm going to now, I have some more slide here. We all also ask the question, look, do you really need to do this test? Because when I talk to people about this test and immune testing, patients always ask me, doctor, do you think I should do all these tests? Because first of all, it costs money. Second is it also takes up time. A month is wasted in doing this test. Is it important, or should I just go for treatment? First of all, like I said, look, if you don't know, if you want to be successful in the first attempt or as soon as possible to reduce your length to pregnancy, then it is better to do all the tests beforehand rather than failing one cycle and start investigating later because you have lost one embryo already. Therefore, it's better to do this. This is to get a proper diagnosis. In any science or any treatment, the important step is to get a diagnosis. If the diagnosis is not clear, is not correct, then you are not addressing the real problem. Then the treatment is not likely to be successful. Therefore, first we must find out where the issue or problem is. That is what is called diagnosis. And then we discuss the treatment options available or any interventions. So this is what is called personalized approach or personalized embryo transfer, because we are not putting the embryo at the standard implantation window, that is standard time we put the embryos back in. Instead, we are putting it according to your body, what it says. That is what is called personalized medicine. And it is important for us to do this so that we treat you according to your body. That's important in this. Next slide, please, Suvir. Now I'm going to hand over to Alan, who is the expert in this field, and he will explain everything about the test. Thank you, Alan.
Thanks, Geetha, and thanks, Suvir, and thanks to Harley Street Fertility for inviting me to come and talk about this test, and thanks for your kind words about, telling you about the test and then you using it and getting success with it. And as you know, Geetha, I only want you to work with things that work for you and your patients. There's no point doing it if it doesn't work. I'm absolutely clear about that. So I'm going to talk you through some of the science behind it. It won't get too complex because it can get confusing, but I think Geetha's done a great job of introducing the background and the test. And so I'm sorry if there's a little bit of repetition, but we all learn better through a bit of repetition. So if we can have the next slide, please. Okay, and you might need to click through a little bit here just for Yeah, so this might look a bit like a sales slide, but I don't want you to think of it like that. This is just to say Igenomix is doing all of these things. And to give you a bit of context, Geetha nicely demonstrated that you have to care about at least two things in IVF. And I'm an embryologist by training. That's where Geetha and I met, me as the embryologist, her as the clinician. And most of my focus was on the embryo. And it's true to say that most scientific progress and effort has been focused on the embryo, and rightly so. But now a lot of emphasis is going on to the endometrium, and I think that's really important, and you'll see why in a second. So we won't go into details about any of these tests, just to sort of show that as a group, Igenomix is very interested in doing more research on all of these aspects to try and get you the best chance of pregnancy and to get you a healthy baby. So if we move on to the next slide, please, Suvir. And this is all supported by genetic counselling, so that's a really important part. So another sort of simplistic way of talking about the embryo and the endometrium is to think of it in terms of seed and soil. And I know you might think, oh, I'm dumbing it down for people. This is how I think of it. Okay, so the seed that you see there is the embryo, if you like, and we're trying to make the best embryo from the best eggs and the best sperm and the best conditions in the laboratory to get the best embryo. So once we've got the best embryo, what are we going to do with it? Well, as you can see in this case, we've got a lovely seed sitting on top of dry, crusty earth. Well, it's never going to grow into a plant because the soil isn't right. If you click through, please, and one more. And what we're really looking for is the best soil as well as the best seed. And when we do that, we've got a chance of getting a healthy plant. So it's just a very good visual to kind of think about what we're trying to do here. We're focusing on the seed. That's all the stuff that goes on in the IVF lab. And now the clinicians have a tool in their hands, which is to do more than just do a scan, but actually do an objective molecular test to find out more about the endometrium. And this isn't something that just we discovered last week. This is based on years and years of basic research and later clinical research. And I'll give you a very brief overview of that research. We haven't got time to go into the details, but there's a lot of research. It's not a new thing, despite what you might hear in the press. If we click through, please. So yeah, that's fine. And again. So we've heard a little bit about endometrial receptivity already, but again, I'll just repeat it so we're really clear about it. Because to be clear, the test called ERA is endometrial receptivity assay or assessment or analysis, and that's just the receptivity. Okay, so I'm going to explain that in a little more detail using some analogies, and then talk about the ERA analysis, which is still the endometrium, but it's a slightly different take. It's like you're looking at slightly different aspects. So we've heard this already. The endometrium is receptive when it's gone through the changes that prepare it for embryo implantation. Now, the endometrium is one of the most interesting tissues in the human body, obviously only present in women. But as you know, and I know it's mainly women who are listening today because I looked at the participant list, it's a really special tissue because every month it changes. And that's unlike most tissues in the human body. So it's a very cool tissue, and it's doing a lot of different things, which, and I'll come to this in a second, which is why we've got quite a complex test to try and understand it a little bit better. The period that we've talked about that we're interested in is this window of implantation. Now, you might say, I don't believe that there's this window, we can transfer embryos at, roughly the right time and it should implant. And the truth is it's not an absolute precise window, but we're trying to get closer and closer to that precision by using objective tests, objective molecular tests, and by understanding that not every woman is the same, that there are differences between women. And a really good analogy, I want you to take this away with you. Carlos Simon, who's the Chief Scientific Officer and the person behind a lot of the research that I'm going to talk about, he puts it this way. Embryos can implant almost anywhere in the body. And, I hope none of you have been unlucky enough to have an ectopic pregnancy, but that is proof that an embryo can stick in places in the body where it shouldn't stick, where it's not meant to stick. So embryos are really sticky. They like to implant. And as Geetha said, they need to have this cross communication between the endometrium and the embryo itself. What they can't do easily is implant in a non-receptive endometrium. So if you think of it that way, the window makes absolute sense. The embryo has to meet the window at the right time. And if it doesn't, it's got much less chance of implanting. If we can move on, please. And we may just click through all of this because that will get us to what we need to see. Yeah, okay. So that's standard timing that Geetha mentioned, this P+5, which I hate all this terminology, and it does get confusing. They're just numbers, but it can get very confusing. So just think of it as P+5 is 5 full days of progesterone or 120 hours. We lab people like to speak in terms of hours. That's a medicated cycle, but that's equivalent to a natural cycle, LH, the LH surge plus 7 days, or a cycle where you use trigger, HCG, plus 7. So think of them as very, very similar. That's called the standard timing. And the reason it's the standard timing is because in most cases where we've done a frozen embryo transfer and used those sort of protocols, it works a lot of the time when we use those exact times, P+5 or LH plus 7. So it's almost a dogma. We've come to believe that this is true for all women, but it doesn't always work. And there's loads of reasons why implantation doesn't work. So we've never really pinned it down. But we do know that, and we've done some research on this, we know that some ladies' windows are longer, they're broader, if you like, and some are shorter. But what this test isn't doing is looking at the length of the window. What it's looking at is where the window is. So for some, the timing's displaced. So there you can see somebody with a window that's earlier. If you can click through to the next bit, thank you. And our data shows that about 30% of women who have recurrent implantation failure, and Geetha gave a definition of that, in different clinicians' hands in different countries, some people will say, oh, it's 2 failures, and some people will say 4, but the standard definition is 3 failures. But I'm sure if you're a patient who's had several implantation failures, you probably think of yourself as recurrent implantation failure. So why I'm saying that is because not everybody who's had this test has had exactly 3 failures. There'll be a whole mix. But if we were broadly speaking, would say that most of the data we have for recurrent implantation failure is probably people with 3 failures. And 30% of those women have a displaced window. So they have a window like you can see in that diagram. It's either early or late. Most of them are early, as I'll show you in a minute, but it's not at the standard time, which means that embryo that's really sticky can't stick there. Next slide, please. And so the standard time for embryo transfer, which would be that P+5, is not going to work for them. So the window's closed. Just think of it that way. I mean, it's not a window, obviously. It's a set of tissues that are ready to receive an embryo. But if it's closed, it's unlikely to implant. So what we want to do is personalize that embryo transfer according to the information we have, and that will give us a better chance. So if we click through, I think there'll be a little thumbs up. So it's not binary. It's not if you're at the wrong time, there's no way it can implant. And it's not that if you're at the right time, it's definitely going to implant. It's a probability thing. Okay, next slide, please. And then just to put some sort of meat on the bones in terms of a cycle, and this might be a little more clinical than you wanted to get, but I'm sure you've had some experience with this. It is simple, but this is why we have to really spell it out. If you're starting your progesterone, we call that day 0. So 5 full days, as you can see, 5 times 24-hour periods, that gets you to P+5, and that's where we say to do the biopsy. Now, we've got a very good predictive algorithm, so we can take tissue from sort of almost anybody and work out what stage of the cycle they're at. But what we want to do is always take it at P+5 and then be able to say what they need to do next. Because if everyone did biopsies at completely random times, not only would the algorithm start to crack a little bit, but actually you'd be saying to people, wait there, you took it at this time, so let's change your progesterone and then do this, and it would just get very complicated. So we say to everybody, do P+5, and then we'll tell you what you need to do from that point. That's your standard starting point. Next slide, please. Okay, so this is quite nice because this now shows you 150,000 data points worth of information and what we can see. It also tells you that we're not at this simplistic level now of just saying you're non-receptive or you're receptive. We've got a lot more nuance because we've trained our algorithm with all this data to be much more sophisticated and give you these following categories. Now, obviously, actually, I won't say this is the thing you should be most interested in, because if you're having this test and you've had lots of failures, you're probably, and I hear this from lots of patients and lots of doctors, you're probably going to be sort of happy if you've got a window that's different, because you're going to say, I've got the reason why it didn't work. And that often makes people happy because they say, I now have a reason, I now have something I can change. In a way, getting the receptive result after you failed lots of times kind of leaves you no better off, because you say, well, the timing's the same, so what do I look for now? And I might have an answer for that in a couple of slides time. But as you can see here, we've now got early receptive, receptive, and late receptive. Of course, we're heading for the center of that, the receptive. But if we got an early receptive result, that's absolutely fine. We're just going to adjust the timing of progesterone for the transfer cycle to a small degree. But I don't want you to, well, you can sit there with a calculator and add it up if you like, but early receptive, receptive, and late receptive, if you clump them all together and say basically receptive, that's about 60%, as you can see, just over 65%. So that leaves the rest of the results as non-receptive, and they're predominantly pre-receptive, as you can see, the ones on the left-hand side, and a few post-receptive. And pre-receptive is just a matter of doing more exposure to progesterone. It's not more progesterone, it's more exposure to progesterone, a longer time of exposure. So starting it earlier and doing the transfer later, if you put it that way. The post-receptive, think of it almost like the window is slamming shut. So it's much harder to work with, because once the window slams shut, that embryo isn't going to stick. Again, I'm trying to give you a visual aid to think about that. And then something that's really nice about having more data and having a stronger algorithm is when I started Igenomix in 2017, we had this test. It was a more of a, I won't call it a prototype test, but it was an earlier version of the test. So it wasn't so predictive. And probably quite a few clinicians in the UK and elsewhere would know that they sometimes had to do more than one biopsy. And it was quite common. It was, between 20 and 40% of the cases had to have 2 biopsies to try and find that window. The first window was just too far out. So we changed the timing and then we do it again. Now we've hit receptive, good. But now only 8% of cases need to have a second biopsy. And they're mainly in that post-receptive part. So most of the time you're only going to do one biopsy. And I think that's really important, because it shows that we care about trying to do the minimum of these procedures and the minimum of costs. And we want to be proud to offer a test that gives you a very good result. Next slide, please. And this isn't about looking at these publications. This is really just to say there's a lot of background work that has gone into developing this test. This isn't just let's have a little go. There's lots of fancy machines. I'm sure we can figure out a test. This is based on basic research and then clinical research. And then even, as you can see at the bottom there, what's known as the gold standard piece of evidence for providing a test, and that's a randomized controlled trial. And that's the only one I'm going to show you some information on, because for the interest of time, but also because I think it's a really interesting study that was published recently. And so our publications are not just ones that we've done. There's quite a few publications out there that are customers, people who've tried the test and they've published it themselves. We've not pushed them to publish anything, and they showed good results. So this is just the front page of the paper if you want to look it up. But I've got a summary slide coming up, please. That's it. So the take-home messages really, and if we click through, so I can just give you some of these numbers. There's improvements in every single thing that's looked at, and these are all important parameters as a patient and as a clinician you'd be interested in. So the asterisk is when it's statistically significant, and as you probably know, that's when you say I'm really sure that result is not just by chance. Okay, now there's a few results in there that look good, but they're not, strictly speaking, statistically significant. An example would be live birth increase between a frozen embryo transfer and using ERA, using a personalized transfer, and using a fresh embryo transfer versus ERA. So that's not significant, it's not statistically different, but it is different. And that PP means percentage points. Now, I don't want to get too sort of technical with you if this is not something you're familiar with, but it basically means, imagine you had a 30% success rate. This means adding on those percentage points. So an extra 10 percentage points means you've now got a 40% success rate. So we're not doing relative success here, we're doing actual percentage points, which is, really valuable increases in success. And really the take-home message here, because of course we're interested in implantation rate and pregnancy and cumulative pregnancy, but what we're really interested in, cumulative live birth rate. So in 1 year of transfers coming from these 3 arms of the study, we've got significant increases using a personalized transfer, based on the result we got from the biopsy, versus doing a standard FET, frozen embryo transfer, or a fresh embryo transfer. So that's what, there's a lot more in that paper, but I just wanted to give you those take-home messages. So this is the sort of thing that the HPA and other bodies are always saying, give me a randomized control trial. And now that isn't the only standard of evidence. And I think even the HVA have made a public statement recently to say, we're not going to only consider RCTs, randomized controlled trials. We're going to consider lots of evidence. But given that that's what they like as the gold standard, it's nice to have one for this test. And it's taken a long time. It took 7 years to finish the study. So you can see that sometimes patients kind of see the benefit of something and they want it. And the regulators and other people are saying, well, we can't really endorse this until we have more evidence. And often someone in my position says, well, when's the evidence good enough? You know, because it never seems to make people happy, however much evidence you have. Next slide, please. And so this is just an example of sample report. If you haven't had one of these, it's nice and simple, actually. I mean, this is quite a simple kind of report. It's very clearly saying what status you have for your endometrium for when your biopsy was taken. And this one says pre-receptive. It says when we think you should do an embryo transfer, you know, the timing. So not 120 hours in this case, it's saying because you're pre-receptive, you need to do it 147 hours, which, as you can probably work out, is just over a day more progesterone. And don't get too fixated, because I've heard this from a few patients and doctors about this plus or minus 3 hours. This is not as precise as 3 hours. You know, this isn't to the point where you're looking at a stopwatch and saying, I must do the transfer now. You know, we've hit that second. It's giving you a bit of leeway, okay? Because really the algorithm's probably giving you between 6 and 12 hours kind of precision. But this is so that you don't say, if I've missed 147 hours, you know, it's doom and gloom and it's not going to work, because that's not the case. And that's particularly true if you're transferring the embryo slightly earlier, because the embryo can wait around until the window's open. What it can't do is implant very well if the window's closed. And then there's just some more details below, you know, telling what you should do if you do a day 3 embryo transfer, because you can still use the result, and a bit more about the actual profiles we've seen in other women. So quite a lot of information there, but the headline is that pre-receptive. And that diagram, by the way, I know you won't do this, but I have spoken to a few scientist friends of mine who thought that that diagram was kind of a precise diagram. You know, they got their ruler out and said, well, that little triangle, does that mean that I'm this far along the pre-receptive? No, it's just a schematic to say you're falling into this particular bracket. Next slide, please. So now we're going to change tack a little, and we're going to talk about the endometrial microbiome. Now, this is different. This is not receptivity. I want you to think about receptivity in ERA. I want you to stick that test into the receptivity block. This, I don't think, is necessarily receptivity. So it's not necessarily about, because we don't fully understand it. That's one of the reasons. This is not necessarily about, is the embryo sticky in this environment? This is more about somehow the microbes, the bacteria. Yeah, sorry, it's bad news, ladies. The bacteria that are in your endometrium can have an effect on whether the embryo will implant or not. Now, it's probably not a surprise to most of you, because I'm sure lots of you drink Yakult and other things like that, that you've heard a lot about the microbiome, and that it's becoming a really hot area of medicine. Well, there's some fun facts about this. You know, it's the invisible universe of bacteria that lives within us and on us, and everywhere in the universe, really. There's at least, that people argue about the number, at least twice as many bacteria in our body than our own cells. So you could argue we're not really humans, we're bacteria that are carrying humans around. They're basically everywhere, but you've heard a lot about the skin and the gut, I'm sure, because we're always being told to wash our hands. So that's the skin part. And the gut part, you know that when you visit a different country or you eat different food, you know, your tummy changes, you know, things change and you have to adapt to that. That can also have quite a lot of different effects in different parts of your body. And that's the really exciting part of this whole new area of research. A 70 kilogram person has about a kilogram of bacterial cohabitants. So, you know, that's interesting to think about, isn't it? A big chunk of bacteria in you. And this is quite interesting because it does relate to our test. About 20 to 60% of the species that are present within humans can't be cultured. And what I mean by cultured is, you know, grown in a little dish so that you can say, ah, that's there. And why that's important is if you use a culture method, which is what quite a lot of tests are, that means you're going to miss 20 to 60% of the information that's available. So by doing a direct test, you know, a direct molecular test that basically says whatever's there, I'm going to spot it. You know, think DNA fingerprinting. Think of it in that sense. You know, I'm forensically looking for a trace of something that was there. That's what we're doing with our test. We're not saying let's grow it and see if it grows. And if it doesn't grow, we'll never know whether it was there or not. We're directly looking at it. So if we move on, please. So our initial research. I mean, I'm sort of condensing a lot of research into a couple of slides here. Some key things that we found is that the endometrial microbiome or microbiota has an effect on implantation success or failure. Now, this started with a quite small paper, very few numbers, which are very compelling, but they made us want to look at more. Understandably, you can't start making big claims on small numbers. The other thing, though, and this is quite critical that you remember this point, is that although your endometrium is the next place along from your vagina, it's not necessarily the same. It's often the same, but it's not necessarily the same. So there's a lot of tests out there that look at the vaginal microbiome, and often the endometrium will have a similar set of microbes there, but they're not necessarily the same. And we've got, and I'm not showing the slide on this, but we've got lots of evidence that there are many women where it's not the same, which means it's potentially unique. And if it's unique, we can't look at the vagina to tell us what's in the endometrium. We have to look at the endometrium. So that's why we're going to the trouble of looking at the endometrium and not just doing a vaginal swab. Next slide, please. Now, don't get, if you're not particularly technical, don't get too worried about this. Think of this just as the color scheme that it appears. Okay, so you've got bacterial species on the right-hand side, as you can see, and then each of the columns represents a patient. So this, as I said, it was quite a small study, and I don't know if you can see this, you have to twist your head to see this, but that each of those patients has an outcome. So NP means not pregnant, LB means live birth. Don't read them all, don't get fixated on that. I'm going to show you the results in a second, but this was one of our initial studies, and those colors are called heat maps. So what that means is if it's really burning red, it means there's a lot of something there, and if it's pale, it means there's not much there at all. So as you can see, what are we looking at here? Lactobacillus on that top row. You can see that some patients don't seem to have much lactobacillus at all, those ones on the outsides of this particular heat map. And the ones in the middle, they're really, burning hot with lactobacillus. And then similarly, if you look down below, you can see some particular species of bacteria. And I don't know if you're familiar with these, but I think most people have heard of streptococcus, usually in the throat, not usually good news. And most gynecologists know that Gardnerella is not good news. And as you can see, it's not absolute here, but the patients to the outsides on the extremes, they seem to have fewer lactobacillus and more of these pathogenic microbes. Okay, and if we go to the next slide, we're going to categorize them in a slightly different way. So now if we look at that block of patients in the middle, we can call them lactobacillus dominated microbiome or microbiota patients, LDMs. And that's where there's more than 90% of the bacteria that we find in the endometrium are lactobacillus. And you've probably heard of lactobacillus. That's the good bacteria in Yakult and yogurt and things like that. Now, I don't want to simplify it to the point of saying lactobacillus is good, everything else is bad, but it's a nice way of thinking about it. It makes it simpler. If you click through, please. And those ones on the outside where they don't have so many lactobacillus, and as you can see, it's not absolute here. We call them non-lactobacillus dominated, where they have less than 90%. Don't get fixated on the 90%. I always say this to my clinician colleagues. It's not an absolute number. It's a sort of, it's a proxy for most of the things that are lactobacillus, or it's definitely not the predominant species there. Next slide, please. And so when you turn that into a table rather than a heat map, if you click through, you can see that LDM, which is the one where we've got lots of lactobacillus, and the non-LDM, which we've got very few lactobacillus, there's massive differences. They're small numbers, and I absolutely accept that. They're small numbers, but the differences between the outcomes, pregnancy rate, implantation rate, ongoing, if you click through, are vastly different. Not subtly different, they're vastly different. But no scientist worth their salt would say, oh, let's, this has changed the field based on, 30 patients. You need more patients, okay, to really demonstrate something strong here. But it's very compelling. Ignore that sort of data at your peril. So, we've got the first, this is a little aside from just one case study. So this is just one patient. This is not, scientific evidence, randomized trials. This is just very interesting because we wouldn't normally have done this. A lady had 2 biopsies done, one in a cycle where she had a miscarriage, one in a cycle where she had a pregnancy. So it was unknown that she was actually pregnant. And my point here is we wouldn't normally do that. We don't normally taking biopsies when someone's pregnant. That was, done inadvertently. But what you see here is a slightly different version of the color map here. But The one where she's pregnant, it's predominantly lactobacillus. And the one where she had a miscarriage, it's like the colors of the rainbow. There's all kinds of bacteria there, and there are lactobacillus, but they're an absolute minority player. So this is not, I'm not calling this evidence, but it's a really interesting case study, given that we didn't get to choose this. This just happened by chance. And it does sort of provide a little bit of a window into, what do you want to see to support a pregnancy? And what you want to see is lactobacillus dominance. Next slide, please. So now we're looking, this is a paper that's in preprint at the moment, so it's just about to come out and be published. It's the same author, same group, and this is doing the same thing that you saw, or very similar thing that you saw in a few slides ago, but on a much larger patient group. If we go to the next slide, there we go. And the data is being shown in a slightly different way, but don't worry about that. The key sort of points are exactly the same. So lactobacillus on the left-hand side, this -1 to 1.5, the numbers are irrelevant. But if you start from 0 in the middle there, anything that's above 0 means you're lactobacillus dominant, and anything below 0 means you're non-lactobacillus dominant. And as you can see, there's a massive tendency to have a live birth or no pregnancy. And you might say, well, no pregnancy, but as I said earlier, and Geetha said, there's lots of reasons to have no pregnancy that are nothing to do with the endometrium. They could be to do with the embryo. But here we're seeing the difference between live birth and biochemical or clinical miscarriage, biochemical pregnancy or clinical miscarriage, adverse outcomes, if you like, are more likely to happen in the non-lactobacillus dominant group. So although we're showing the data in a different way, it's a much bigger group, 190, as you can see. And this is absolutely supporting the finding that we had earlier. So this is really good news in terms of, does looking at the microbiome and classifying it this way give us a really good biomarker for patients undergoing IVF treatment, and possibly, and here's the really interesting thing, possibly for patients who aren't going through IVF. So we may be able to say something about your chance of having a clinical miscarriage, whether you're going for IVF or not. Next slide, please. So this, I think that's just, yeah. So conclusion, it's a great biomarker to predict reproductive outcome and opportunity to further improve diagnosis. As Geetha said, it's really important to get diagnosis and to do an intervention, a treatment strategy, do something different. And the key species we think are, really important are lactobacillus, i.e. we want more of it. And the one we've seen that keeps cropping up and again, and it's not this isn't a, if you've got something bad happening, it's definitely Gardnerella. It's just, it's becoming a bit of a persistent offender. We're seeing it quite a lot. So we're thinking, there may be more of a story here. It's clearly not good to have a pathogenic bacterium in your endometrium, but maybe the one you see more often with bad outcomes is Gardnerella. That's my point there. So just quickly talking about giving them their names, Emma and Alice. If you click through, please. Yeah. So what I want you actually to take home with you is, it's just going to sound a bit weird. I don't think you should focus on Alice at all, is my feeling. Emma looks at everything. It looks at every single bacteria that's there in the endometrium. It can determine the percentage of lactobacillus and any other species present, which is either pathogenic, i.e. bad, we want to treat with antibiotics, or dysbiotic. Dysbiotic really means, think of them as passengers. Okay, think of them as they're there. We're not quite sure what they're doing, but what they are doing is taking up space that a good lactobacillus would have. Okay, and what we want to do once we get an abnormal result is have a personalized therapeutic solution to help with that reproductive prognosis, to help with that change that we want to get a good outcome. And the reason I say sort of ignore Alice is because Emma includes Alice. Alice is just a subset of 10 bacteria most commonly associated with chronic endometritis, which is actually a very difficult condition to detect in a woman. And so my feeling is that there's not much point doing Alice, because if you do Alice and you find something, you're not going to know anything about the lactobacillus. So you might treat the pathogenic bacterium with an antibiotic, and then you're probably going to be asked to use probiotics afterwards, but you're not going to know any different. And so Emma's giving you all the information. Next slide, please. And this is just sort of showing you the kind of results that you can get from this. So we're taking our biopsy. It's the same biopsy as we would use for ERA. So you can either do it alone or you can do it at the same time as an ERA, and that's quite important. I think you might need to click through this one. So on the left-hand side, you can see a normal or a negative result from Emma and Alice. Just do the transfer. You don't need to do anything different. Ultra low biomass or dysbiosis, that's another result you can get on this report. That just means we can't find hardly any bacteria there, which isn't really normal. because bacteria are everywhere. So we say treat with probiotics. So it's a bit like giving your endometrium a boost, just like, you know, when you come back off holiday and you've been really ill and they say have yogurt because or Yakult because you're going to repopulate your gut with good bacteria. And then there's the EMA abnormal falls into two different categories, either ALICE negative or ALICE positive. And that just means we know something specifically about the 10 bacteria that are most commonly associated with chronic endometritis. But as I said, if you do an EMA, you've got all the ALICE information anyway. And what's really interesting, and I'm glad we went down this pathway at Igenomix, is if you get one of those results on the right, we're going to do the second test. We're going to sort of recommend what you do in terms of treatment, and we're going to offer the second test for free. So we want you to clear that infection and use probiotics and get a normal result. That's what our aim is. So we're not trying to overtest. We want to clear the problem. Next slide, please. And I think I've got, yeah, this is a sample report. I know it's quite busy. There's a lot of information on there. But as you can see, it says, what's the highlight result? So on this one, EMA test result is abnormal microbiome. So as soon as you see the word abnormal, it means you've got to do something. And that's what I love about the test. That's why I joined Igenomix, is they do tests where you can do something about the result. It's not just, oh, sorry, here's a result, bad luck, off you go. It's, here's the result. I'm sorry that's not what you wanted, but I think we can do something about it. And I think that's really important. The ALICE result on this, it's all part of EMA, is it's positive for specific pathogens causing chronic endometritis. And as you can see here, that's Streptococcus in this case. I've highlighted it in red, and Lactobacillus is down, you know, and it's down because there's Streptococcus there and some other things. Others will be the dysbiotic bacteria. So if you've got Streptococcus, you want to clear it. And if you've got low Lactobacillus, you want to replace it. So as you can see in my little boxes, green, low Lactobacillus, use probiotics to restore the Lactobacillus content, and Streptococcus, use a specific antibiotic to clear it. And we give a recommendation, as you can see on the left-hand side, and that's been recommended by a microbiologist. So it's not, you know, it's not just press a button and get a result, get a, you know, kind of a script there. This is somebody who's actually reviewing it and saying, this is the latest information we have, this is what we think you should use. And why I say that is because there's a, you know, not amongst clinicians particularly, I'm just saying, you might think, why don't we just take antibiotics all the time? But you know as well as I do that there's a big fear about antibiotic resistance. But also you want to target that bacteria with the right antibiotic. You don't just want to hit it with anything. Next slide, please. I think we're done actually, but yeah. So just, you're probably wondering why it's called TRIO. It's called TRIO because there's 3 tests, but it's also Endometrio in Spanish because our headquarters is in Spain, means endometrium. So that's one of the reasons it's called Endometrio. So we want to, you know, what's the role of doing this sort of triple test, which in a way is like a double test, as I've told you this dirty secret, really. We want to optimize outcomes at the start of treatment, personalized embryo transfer. That's focusing on the receptivity. We want to help recurrent implantation failure patients, which is also ERA, but might be part of that EMA result as well. And we want to also look at recurrent miscarriage. And we can argue about what recurrent means. I think to a patient who's failed, you know, twice, I think quite rightly, she thinks that's recurrent because it's happened twice and she doesn't want to happen again. So I think we can split hairs over what equals recurrent. There is a formal definition, but I don't think we should get too heads up about that. I believe in the future, we haven't got data on this at the moment, or not very much data, that recurrent miscarriage and using EMA might actually help people who aren't even going through IVF because it doesn't require you to go through IVF. What was the other thing I was going to say? There was, yeah, standard, well, yeah, I'll come back to the other thing. Standard pathways and consistent protocols is really important. And I can tell from the way Geetha, you know, framed what she's doing that she's trying to put in place a sort of a roadmap for you to help you navigate this. Now, there's always going to be little changes to that depending on who you are and what your circumstances are. But we're seeing with the clinics we're working with, the best results are coming from people who are using it in a quite standardized way, not a rigid way, but a standardized way. So when does the patient have a test? And this is just some examples. This is not this is what you must do, but we're finding that, you know, people of advanced maternal age, that's what AMA stands for, because they feel like their embryos are precious because they might not have many more, because they might not have many more eggs. They don't want to waste an embryo on a suboptimal endometrium. So maybe a younger patient who's got more embryos might say, oh, I don't need to do ERA yet. I've got embryos that I could use and I'd like to give it a try without ERA. And that's absolutely fine. so I'm not trying to say to people, no, you must use ERA every single time. I'm just saying I understand why different patients might have different pain points for why they'll do a certain thing. Next click, please. But I've written here, how many implantation failures do you need to want to do it? And we're speaking to lots of different clinicians around the country, and they've all got different opinions about when to do it. But I think that's a good thing to talk to you between patient and clinician to kind of come up with where that needs to be done. Previous miscarriage looks like that might become an indication for Emma, but we're gathering more data about that. How's the test performed? Excuse me. Click through, thanks. We think the best results, the most precise results, are from doing hormone replacement therapy, an HRT medicated cycle for FET, because there's a standardized dose and administration, and the timing is really, really clear. You can use this for a natural cycle for FET, and you can get good results. But understandably, in a natural cycle, you don't have so much control over when the LH surges and the timing. If you click through a little bit. Yeah, sorry, can you click through again, please? Yeah, and a natural cycle for Emma is to do it between 25. So you're not doing the progesterone days as we saw for ERA. If you're only doing Emma standalone, you're doing it between days 15 and 25, and that's mainly because the pH, the acidity of the endometrium is conducive to, it's sort of more stable for looking at the bacteria at that time. Okay, and I'm so embarrassed because I forgot to say something really fundamental about that randomized controlled trial, which has a big bearing on which patients might benefit from ERA. That trial was not recurrent implantation failure. So it's quite nice. I can do the big reveal now. I should have done a drum roll. It was actually patients who were going through their first cycle of IVF. And why that's kind of exciting is that maybe you don't have to have lots of implantation failures to consider whether you should use ERA or not. And again, that's not me saying you must do it. This is the thing you should do before anything else. But it's evidence and support for doing it without having to fail first. So all of our data before that was really on patients who had failed multiple times. And we said, we've run out of other things to do. Maybe it's because your endometrium isn't receptive. And now from doing it on the first IVF cycle and saying it works even for patients on the first IVF cycle, you don't need to have failed. That's good news. Next slide, please. Yeah, I finished. So thanks for your time. I really appreciate your time. I know it's Friday and you're probably wanting to move on with your weekend. I hope it's been useful. And I'm happy to answer your questions, which I know there's a few in the chat already.
Thank you, both speakers. Those were very informative talks. Another thank you slide, I'll just click through. We will, of course, turn it over for questions, but actually, before we get onto that, I want to add, I think this is a fascinating area because IVF success rates, as most people will see, they've been creeping up and up. But the best success rates we can achieve these days are somewhere around 50–60%. So there's still a 40% where we don't know why it's failing in a lot of cases. And I think possibly we might find some of the answers in this area of research because we've hammered the embryo to death almost. We've figured out what makes a good embryo, but there's a lot of questions to answer in this area. And it's funny because, Alan, you mentioned it, which is that the HFEA take a bit of a dim view of these newfangled tests, as they call them sometimes. But this is sort of where the research lies. And these are the questions we have to answer. So I'll stop prattling on and I'll actually turn over some questions. So the first one we've had is, thanks for the webinar. The ERA, how long is it valid for? And also how soon should one have IVF? Essentially, how long is this test result valid for? I'd like both the clinical view and the laboratory view, if that's all right. So Dr. Venkat, I can start with you.
Yeah, actually, that's a very good question. I feel generally, if you have marked this most receptive stage of the endometrium, it should stay same in the women. But however, but like Alan pointed out, if the woman has had some surgery to the uterus and things might change, so then we need to redo it. So it's not a question of time. It's a question of whether there has been any changes in the intervening periods, or the woman has had some immune treatments which contributed to changes in so many different things, which could have also have influenced it. We don't know much about it because we don't have any studies based on this. And that is why it's important to know if things have changed in between. And if that there has been no change in the woman's life or in the uterus particularly, then I don't know. I will ask Alan whether we should repeat it, say after a year, because one of our patients did it last year. She asked us whether to repeat it, and I phoned somebody in your lab, and they said she has had immune treatments. It might be a good idea. I didn't say we must do it. Might be a good idea, and the lady wanted the best for her before her treatment, so we repeated it. But this is a question, yes, we get from some patients.
Okay, do you want me to?
Yeah, please.
Yeah, so I don't disagree with anything that Geetha said. I'll just frame it in a slightly different way. We've got some evidence for patients 3 years and 5 years after doing an initial ERA, and they've got the same result. So, but I'll be a bit more specific and put some caveats in. So we believe that exactly as Geetha said, if you haven't had some major change to your body, through surgery or chemotherapy or some big, some disease that required lots of drugs, we think it's a stable result. Okay, so really the way to think about that is, always give all the information to your clinicians when they're treating you, because if you've had some big change, you should tell them, because it could have an impact. And what usually happens then is the clinician will contact us, and we'll contact our clinical team and we'll say, have we ever experienced this particular case before? And they'll say, yes, this did happen, and this is the result we got. But the reason we don't have huge amounts of data saying, it lasts for 3 years, 5 years, 10 years, is partly because it's a relatively new test, but secondly, because to get that information, you have to do multiple biopsies on the same patient. And you can understand that a lot of patients wouldn't want to just do the biopsy just to get information so they could say, yes, it's stable for X years. So really, I would say the best way to frame this at the moment is to say 3 years, it's probably good. If you have any significant changes in your body, your physiology or surgery, then tell your clinician that, and we'll all work together to make sure we're happy that we don't need to retest, or we do need to retest. But our aim is to test as little as possible, honestly.
Follow-up question to that. What about weight change?
I don't know if we've got a lot of data on women whose weight has changed massively, or let's put it a different way, their BMI.
Yeah. But
what we have got is that women whose BMI is stable, whether that's low or high, if we get a decent endometrial sample, we get a stable result. So it's not. So I know that doesn't directly answer your question. I don't think we've got a lot of data on women who've got massively different BMIs as through the years, but ones whose BMIs are quite different from each other, we can get a good and stable ERA result.
No, I presume it's stable, as long as the person stays roughly the same. That makes sense. But I think if the physiology changes and the endocrinology changes, you would expect it to change. So, because it is something, sometimes you have patients who are slightly overweight and they get healthy for a pregnancy, and they drop some weight, or in some cases they put it on. So they're at a healthier BMI, because that's often something that changes with patient behavior. So that would be quite interesting. Okay, the next question that we have is, do clinics in the UK, or does Harley Street Fertility Clinic offer PRP? I'm not familiar with it. I think I'll pass that on to you.
Yeah. Okay. So this is given as an injection. So what they do is prepared serum, platelet-rich plasma. That is what is known as PRP in short. It's prepared from the blood, and so it is taken from actually the blood of the person, that is the woman, and then injected into the ovaries or the uterus, depending on where there is some problem. I actually learned about this PRP actually from a taxi driver. You may not believe this. I have to, I can't control myself from telling this story. Sorry, I won't take long. Once I was traveling, this was some 10 years ago. And then when I was coming back, he drove me from Heathrow to my house. And then he just, casual conversation, what do you do, etc., etc. Then when I told him I'm a doctor, then he said, oh, I want to ask you something, you know what? He said, I'm losing a lot of hair. So what do you think of PRP for hair loss? that's the first time I heard about PRP for hair loss. And of course, I've heard about other things like, PRP for low ovarian reserve. And that's why I heard. And then he told me, look, a lot of people are interested. It's working very well. So I did a lot of research. Now they're doing some research, and it's coming in human trials with PRP in countries like Italy, Spain, and Greece. I've heard about it. They're presented in conferences, but still it has not been approved for human use in the clinical use. It's supposed to rejuvenate or like a stem cell. It produces more egg in the ovaries or primordial cells for the egg. And again, if the uterus is atrophic, like Asherman syndrome, we inject into the uterus, then it can help in the production of endometrial cells and make the lining thicker. So that is where the PRP comes. But as I said, it's still not in clinical use.
Thank you. The next question that we have is, what, if any, benefit does ERA have for someone who's only doing fresh transfers? And actually, Alan, I was going to ask you this based on your talk, because how do you deal? So, in a fresh embryo transfer, we talk about synchrony between the embryo and the endometrium being important. So how would you deal with this? And how is ERA relevant in fresh embryo transfers? Because we only do them in frozen embryo transfers, really.
Yeah, so the unfortunate but easy answer is it's not relevant in fresh embryo transfers. So this is only relevant in frozen embryo transfers. And one of the reasons for that is because everything is much more controlled in a frozen embryo transfer. If you're using a medicated cycle, everything's much more controlled in terms of the hormone profile, and it's very different in a superovulation cycle. So we don't have that's not something we have data on. It's I'm sure they looked at that in the early days and found there was no signature, no molecular signature, no profile they could look at that made any sense. I'm not saying it will never be there. I'm just saying at the moment we don't have that. So this is only, so the golden rule, if you like, is this is for frozen embryo transfers only. And I know that's disappointing news for people doing a fresh embryo transfer, but the reality is that most people who do a fresh embryo transfer, if they're lucky enough to have a few embryos, will probably end up having a frozen embryo transfer as well. So at least we can help them after that initial fresh transfer.
Thanks.
Alan, one of your slides mentioned about success rate with the frozen and fresh ET, is it not? I don't know.
No, that's from the trial though. That's 3 different groups in that trial. One's having a fresh embryo transfer, no ERA at all. Okay. One's having, one, I should have, I didn't have time to go into it. One's having a frozen embryo transfer with no personalization, no ERA, and one's frozen plus ERA.
Okay.
Yeah, I should have said that. Sorry.
Thank you. Next question we have is, do the results of your studies show that you should have more or less lactobacillus in your body? Alan, if you don't.
Okay, so I'll be a bit more precise then, just because, when I get that question, I want to be sure I know what the question means. So I don't want to answer body, I want to answer endometrium. Okay, because I'm not talking about the body, I'm talking about the endometrium. So I'm not saying drink loads of Yakult and your gut will be full of Yakult. We can't think of a mechanism whereby drinking lots of yogurt would get to your endometrium, which is why the treatment is vaginal probiotics. Okay, so but the short answer to your question is, based on the data we have so far, we think you should have more lactobacillus in your endometrium. So I hope that answers your question.
Yeah, I think that's quite clear. The next question we have is, I've had 2 miscarriages from FET. Would this be beneficial for myself? I have no tubes from 3 ectopic pregnancies in the past, hence IVF, and I also have PCOS. And I have had I've had 2 cesarean sections with my child. Dr. Venkat, if I can ask you to try and answer this one, if you think it would be a useful investigation.
Yeah, I think Alan gave the answer in his presentation. He said that, miscarriage, it means implantation is happening. That means there is no doubt about the implantation window or the most receptive phase of the endometrium. Only test which will be useful here is EMA, because he said that when there is a non-lactobacillus dominated endometrium, the risk of miscarriage is there, and biochemical pregnancy. I think it will be useful. What do you think, Alan?
Yeah, absolutely. God, I'm glad. I'm so glad we're on the same page. We didn't plan this answer, you know. Yeah, I agree. I'm not saying, you know, none of this is this will work. You know, you just need to use Emma and it's going to fix all your problems. It's more about getting a better handle on what happened and trying to understand. So I would agree. I think Emma is one option here, but I also think I'm going to throw something else in here. I also think that although you've been successful before, and that's great news, you're obviously implanting. The embryos are good enough to implant. And you've proved that by, unfortunately, by the miscarriage and by the previous child. But there's no guarantee that these miscarriages weren't chromosomally abnormal. So potentially being able to check whether the embryo is chromosomally normal, and every woman has abnormal embryos at some point. So that's another element. And of course, there's other things too, but these are just the things that we can focus on and we can address.
Thank you both. This is an interesting question. So if I had an ERA done with cyclogest, 400 milligrams twice a day, if extra progesterone were to be added, would that make a difference? So they're not changing the timing necessarily, but the strength of the progesterone. So if they were to add something like Lubion or Prontigest, particularly from the transfer day, would that make a difference?
I think Alan said it. It is the length of the progesterone used rather than the concentration or amount of progesterone in the endometrium. So by increasing say, giving another progesterone preparation, I don't think it's what we mean by that pre-receptive phase or post-receptive phase. It is the duration of the progesterone administration. Is that right, Alan? Correct me.
Yeah. But also, I think this questioner is saying after you've done the transfer, which would be the same as, you know, after you've done the biopsy, if you add extra progesterone in, then is that going to have any influence? Well, it's not going to influence the ERA result and the time of the transfer. All I would say though is if you start doing different things between a biopsy cycle, and a biopsy cycle doesn't mean anything once you've done the biopsy, obviously. But if you're saying, should I add extra progesterone because that's going to support the pregnancy better, which I know has definitely happened because I transferred at the right time, that's a difficult one to answer. I mean, and it's complex because there's been some nice guidance recently about adding more progesterone support and claiming that it's based on a strong randomized controlled trial, which I've heard conflicting views on. So it's not an easy one to answer. But in terms of, if we stick with, you know, timings of ERA and transfer, it's very clear that that's about the duration and not about the amount of progesterone.
Yeah, and I would like to add here that, yeah, if you want to add additional progesterone, then actually the progesterone should be measured. We do that in our clinic, actually. Before we do the embryo transfer, we measure the progesterone, and we should have the optimal level of progesterone for the embryo transfer on the day. And if we find that in some women it's extremely low, and then we add extra progesterone, that will be useful in those cases. So if you measure the progesterone, that will tell you whether you need to add some more progesterone or not. But for the ERA, it is the duration, not the amount or concentration of progesterone. These are two different things, if I understand correctly.
Yeah, so I think, and the follow-up sort of extra information to that question was that the progesterone level was low on my embryo transfer day in the previous cycle with only cyclogest. And the follow-up question is, what is an optimal level of progesterone?
And I'm going to have to hand that over to Dr. Venkat.
So optimal progesterone level for an IVF pregnancy is something like in the region of 70, 80. And so in our clinic, we keep it as around figure of 100, because sometimes the progesterone also fluctuates a little bit. So, and we don't want it to go down, because there are lots of PCO women where the progesterone is low, and initially it is at a higher level. Slowly it goes down, and such women would have noticed spotting before their periods because the progesterone level drops before the period. So under these circumstances, initially it will be high and it will be going down. So we measure the progesterone in such cases at regular intervals to monitor the progesterone after the embryo transfer. But anyway, if you noticed it in the previous cycle, your progesterone dose should be increased for the next cycle and monitored. So they have to keep it between, say, around 100. That will be the aim.
Okay. We have another question, which is more on GPs and test results, which I'll answer privately. And if there are no other questions, I will wrap up if that is okay. So I'd like to just remind everyone to look at all your relevant options. So as Alan mentioned, whether you're having IVF or not, sometimes these tests may actually be relevant. Talk to, and we'd love you to talk to us, talk to your clinic or your specialist you're seeing already. Don't, ask all the questions that you might have. Make sure your questions are answered. Please don't forget to stay safe because unfortunately the pandemic numbers are creeping up again because it's winter. Do consider getting vaccinated and boosted if you haven't already done so. We haven't actually fixed our next webinar because it'll be next year, but please do watch this space on our website to see our schedule that will be released shortly. And so all that really remains is for me to thank the audience for attending. Thank you all very much. I hope it was a useful talk. And then I'd like to thank our panelists. Thank you for your time and your very informative presentations this evening. And I'd like to wish everyone a lovely evening and a very good weekend. Thank you all. Take care.
Thank you.
Thank you.
Thank you, Alan.